hypoglycemia. Recurrent episodes of hypoglycemia may lead to stroke or arrhythmias. Hence, KDIGO recommends HbA1c target of 6.5 to 8% in patients who are not treated with dialysis and less stringent target for the patient who are on dialysis. So now coming to the pharmacotherapy. In 2015, the entire narrative changed with entry of empagliflozin. So in EMPA-REC trial, the empagliflozin showed that it causes the stabilization of the eGFR and even causes the improvement over the long-term use with reduction of cardiovascular mortality. So these fluoresceins are isolated from bark of apple tree and causes the reduction of HbA1c by 0.6%. Now how do they act? As we can see, the small triangle, blue triangles which are present in proximal convoluted tubule are the locations of SGLT2 inhibitors, which causes the absorption of the leaking glucose along with the sodium, causing the decrease in the distal delivery of sodium to these macula densa, which are shown here in brown. So it causes decrease in utilization of ATP, decrease in production of adenosine, which causes the afferent arteriolar vasodilatation, causes glomerular hyperfiltration. So SGLT2 inhibitor restore this tubuloglomerular feedback, except that they also causes the mild ketosis, which provides a fuel for the heart. They causes diuresis, causes the reduction of the BP, and hence cardiovascular mortality. So in the Credence trial in 2019, canagliflozin, it included the patients who were having moderate to severe albuminuria, and it showed that it causes the decline of the eGFR slope by almost 3 times as compared to the standard of care therapy. And it also delays the progression of the disease by almost 15 years. Similarly, the dapagliflozin and empagliflozin in respective trials have shown that it provides a benefit to the heart and kidney, both in patients with and without diabetes. Now the catch here is starting the SGLT2 inhibitors as earlier as possible. When they are being started at a higher eGFR, they delays the progression of the disease by almost 26 years, which is quite huge. So they also have adverse effect and are included in list of sick day medications. Now, in spite of giving the RAS inhibitors and SGLT2 inhibitor, still there is some residual risk. Hence, come in name of Finrenone, which is a non-steroidal mineralocorticoid receptor antagonist. In landmark trials of Fidelio-DKD to study the renal outcome, Figaro-DKD to study the cardiovascular outcome, and the meta-analysis combining the both, the Fidelity trial, which included the patient with stages 1 to 4 CKD and moderate to severe albuminuria, showed 23% reduction in CKD progression. How it is different from conventional steroidal MRAs? It is a bulky molecule with very high affinity for mineralocorticoid receptor with equal distribution between heart and kidney, hence less of the side effect and more of the cardiovascular benefits. Then came the dawn of new era, the GLP-1 receptor agonist. The semaglutide in SUSTAIN 6 and PIONEER 6 trials have already shown that it reduces the decline of eGFR. Then in the FLOW trial, when it was given at a dosage of 1 mg subcutaneous once a week, it showed reduction of major adverse kidney event and death from any cause. The semaglutide, even in non-CKD patient, overweight patient, when it was given at a higher doses of 2.4 mg, it showed reduction in renal outcome by 22%. So how does they act? Acting on the glomeruli, plus the receptors are also present on infiltrating cells like macrophages and T lymphocyte. Hence, it causes the reduction of release of cytokines, chemokines, thereby reducing tubulointerstitial inflammation. The next generation dual incretin agonists are coming up, which are combination of GIP and GLP-1 analogs, which increases the coverage of these GLP-1 analogs and augment glycemic and weight management. So tirzepatide already has shown in preliminary analysis that it slows down the decline of eGFR and reduces the onset of microalbuminuria. The maximum benefit to the patient can be provided when they are given in combination with each other. So that brings me to the end of this presentation. My take-home message will be a multidisciplinary strategy is needed to mitigate the cardiovascular kidney metabolic complications of diabetic kidney disease, starting right from the lifestyle modification to pharmacotherapy. These patients are at risk of hypoglycemia, SGLT2 inhibitor reduces cardiorenal risk independent of effects on glycemic and BP control. So the first line of therapy remains the metformin and SGLT2 inhibitor. The GLP analogs and non-steroidal MRA have demonstrated efficacy in reducing cardio-kidney metabolic risk. So the four pillars of guideline-directed medical therapy for diabetic kidney disease remains RAS inhibitor, SGLT2 inhibitor, non-steroidal MRAs, and GLP-1 analogs. Thank you.
Thank you, Dr. Tarun, for a wonderful presentation. And you have summarized in a very small time, very simplicity, with simplicity, that how to slow down the progression of diabetic kidney disease. As Dr. Bhalla has mentioned, that 1 out of 10 people are suffering from any stage of CKD in India or even worldwide. And this is the fifth most common cause of death all over the world. And every year, 2.5 to 2.7 lakh new patients of end-stage renal disease requiring renal replacement therapy are diagnosed, and almost 30 to 40% of them are due to diabetes. So, and if we see the economic burden, government under the mission of National Health Mission, Pradhan Mantri Dialysis Program for underprivileged people is spending almost 4,500 crores of rupees on the dialysis for underprivileged people. And you can see that this is such a huge economic burden on the government. And as doctors, we have to see that this burden needs to be decreased. So this can be done by, first, primary prevention, second, early detection, and third is slowing down the progression. And early detection, all of you are the pillars of medical health care, and everybody is a nephrologist actually. All diabetic patients should be assessed, or hypertensive patients should be assessed for microproteinuria. That is the earliest sign of renal damage. And if patient is picked up at the microproteinuria stage, you can even reverse the process with all these medicines which Dr. Tarun has mentioned. And I will just again mention that under the dynamic vision of Dr. A.K. Bhalla, he has made a full draft of Indian Society of Preventive Nephrology, because our aim will be to prevent the renal disease or slow down the progression of renal disease. And we are making it, and we will get back to you all, so that you should start working in that manner, so that this burden is decreased. And any questions from the house?
Can we have two burning questions?
For adequate BP control in diabetics with hypertension, ARBs are mostly preferred. Is there any difference in the different ARBs we are having in the market, like losartan, telmisartan, or is it the same?
Actually, in the studies which are being done, which are done for AAC inhibitors and ARB, they have shown the similar outcome. But as we can see for the BP control, it is being seen that ARBs have been slightly better than AAC inhibitors, plus less of the side effects which are seen with ARBs as compared to AAC inhibitor.
You see, all are similar. Losartan is more helpful for even treating uric acid also. So otherwise, this ARB is better than ACE inhibitors, and all ARBs are similar. Because he has mentioned about various trials. They are with valsartan, losartan, telmisartan, so all are same.
My question is, in case of non-diabetic CKD, say interstitial nephritis or contracted kidney, how these four pillars, do these help?
Yes, sir, they definitely help.
In retarding the progression?
Yes, sir. Even the new trials that are coming up with drugs like ACE inhibitors, ARB plus SGLT2 inhibitor, like in case of the DAPA CKD trial, about 67% population was CKD, but rest of the population was even non-diabetic CKD was also there. They have a predominant population of the glomerular disease involving IgA nephropathy, and using the dapagliflozin has shown that it reduces the proteinuria even in non-diabetic CKD, plus it also delays the progression of the disease. So these new drugs which are coming up, even in the KDIGO guidelines, it has been provided that if the patient is not diabetic, then ACE inhibitors, ARB, and SGLT2 inhibitor, if he is having significant proteinuria, then they should be advised for the patient.
How about RAS inhibitors, like say ARB,
They have,
This will be the last question
They
in the
ha-
interest of
yes,
time.
ma'am. They have the definitive role in glomerular disease. They are being considered as the first line of the therapy in treatment of FSGS and other glomerular disease in IgA nephropathy. They have been advocated.
So with this, we close this session. Thank you, Dr. Tarun, for a wonderful presentation.
Thank you, Chairperson. Let's have a huge round of applause, please. Now we move on to an interesting topic in vitro fertilization, single embryo transfer in IVF, improving safety without compromising success. To chair the session, I'd like to invite Dr. Shweta Mittal, ma'am, who is the co-director of IVF at Ganga Hospital, and Dr. Neeti Tiwari, who's the senior consultant, and Dr. Gaurav Majumdar to please come to the stage. Ma'am, to please introduce the topic.
Good morning, everyone. Such keen august gathering with us, and it's a complete pleasure for us to introduce the Chief Embryologist of Center of IVF and Human Reproduction, Dr. Gaurav Majumdar, and he's also the Vice President of a very prestigious society of India called Association of Clinical Embryologists, ACE. With a vast experience of 25 years in the field of embryology, I can assertively say that he is the pillar in our lab to bring the highest pregnancy rates in our country, and we feel very proud that when we work in Center of IVF under the leadership of the embryology team led by Dr. Gaurav Majumdar. So Gaurav, the forum is all yours, and he's going to talk about that how even a single embryo transfer can bring highest level of success rate.
Thank you very much for the kind words and this opportunity, but I think we need to change the, it's the wrong lecture. I think it's the one, it's the one after this. Can we do a slideshow for this? Right. So why this topic of single embryo transfer in IVF, where we are trying to improve safety without compromising success, because now IVF has more or less become a household name where everyone has been touched in some way or the other, where some family member or friend has undergone IVF. And when we think of IVF, one common notion is IVF leads to twins and triplets. And that's what people say, and that's what, you know, everyone come across say that, ki IVF se to siraf twin triplets hote hain. So, all right, now this has to move. So we know that the primary goal of any IVF cycle is to have a healthy baby, right? That is what we all fight for. But such are the market pressures in age that we also understand everybody is gunning for the maximum possible success rates. And one way of doing so is that IVF centers, they do transfer multiple embryos, right, or boost their chance of success. But flip side of doing this, that almost 40% of the transfers will result in multiple pregnancies or in twins. Now, index this much you're getting two and competing family in short. However, in the bargain, sign up and there are many for the babies. There's a lot of premature birth weights, much higher mortality, a very common thing with twins. Not just the babies, the mothers are heightened risk of gestational diabetes, preterm labor, so this is a choice. Now it becomes, after looking at the complication involved, we see that obviously one has to have a single pregnancy. My chances of a pregnant is the number of embryos that we are transferring single in a deal, because of compromise